Malnutrition. Who is at risk and what can we do about it? The demographics of the target population for the Malnutrition Universal Screening Tool, or MUST, is the elderly and dementia patients. Early detection of nutritional imbalance for these high-risk patients is a priority, especially when the patient cannot advocate for themselves. Many times, these patients are nonverbal and cannot make their needs known. Early detection of malnutrition is also proven to be cost-effective and can prevent other medical issues. Malnutrition is defined as a state of nutrition in which a deficiency of energy, protein, and other nutrients causes measurable adverse effects on tissue and body form, composition, and function. Malnutrition is likely to be significant if a person has a BMI of less than 18.5 or an unintentional weight loss of greater than 10% within the last 6 months. Malnutrition can lead to decreased muscle function, skin breakdown, impaired functional status, multi-system organ failure, and ultimately death. There are many treatments available once malnutrition is diagnosed. Some are very simple, from advice to surgical interventions. Dietary advice can include ways to increase intake or exclude certain food items. Like foods high in nutrients and frequent snacking would be a good option. Oral nutrition support include alterations in food and fluid intake and changes in frequency to help increase dietary intake. Change in texture of food, such as puree diets or mechanical soft, nutritional supplements such as Booster and Sure. For the diabetic patient, glucerna is also available. Parenteral nutrition is nutrition that is provided intravenously, delivering amino acids, glucose, fat, vitamins, and electrolytes. Enteral tube feedings is the use of a tube to deliver a feed directly into the stomach or gut. Ilia. Over the last 30 years, Barker states, advances in medical, surgical, nursing, and nutrition support have been made, but there is still a lack of awareness of malnutrition, especially in the elderly. Elia reports on a study that was conducted and showed by using a malnutrition universal screening tool, the MUST, a significant increase in dietetic referrals was noted, indicating an increase in the number of patients identified as at risk of malnutrition. 200 patients were screened using the MUST tool. Out of those 200, 163 referrals were made to a dietitian in a 6-month period. There was a rise of 30 to 40% in a dietitian referrals. A third of these patients were found to be at high risk of malnutrition, that is, with a BMI of less than 18.5. Barker reports that patients who received high-quality nutritional care, like early intervention, plus frequent use of the nutrition services, averaged a 2.2-day shorter period of hospitalization. Barker also goes on to state that these patients who received individual nutrition intervention were significantly more weight stable and experienced significantly less deterioration in nutritional status. Given the high prevalence of malnutrition, routine nutritional screening should result in early identification of patients who might have otherwise been missed. Malnutrition Universal Screening Tool is a 5-step screening tool to identify adults who are malnutritioned or who are at risk. It is for use in hospitals, community, and other care settings and can be used by all care workers. It was designed for use by non-nutrition trained staff and utilizes a scoring system to identify patients at high risk malnutrition and can provide a basis for dietetic referrals and intervention. There are 3 key steps in obtaining the score. Step 1, obtain the body mass index, or BMI. To get the BMI, you will need to measure height and weight. You times your weight by 704 and times your height by itself. Then divide the total weight by total height. If your BMI is less than 18.5, that's 2 points. Step 2 is note the percentage unplanned weight loss. Take your previous weight minus your current weight. Then divide the weight loss by the previous weight. If it's greater than 10, that's 2 points. Step 3. Establish acute disease effect and score. If a patient has been acutely ill and has had no PO intake greater than 5 days, that's 2 points. 2 or more points equals high risk for malnutrition, and a referral to a dietitian is recommended. Bedside speech therapy can also be consulted, and if that is non-conclusive, a video swallow study should be recommended. These tests are done if the patient is having difficulty with a regular diet. If the patient cannot eat effectively, the patient will not be able to consume enough calories, and with not enough calories, will be malnutritioned. Monthly weights, measuring mid-arm circumference, serial calorie counts, and registered dietitian consults are recommended in any at-risk patient. Malnutrition costs the healthcare industry millions of dollars a year on treatments. ELEA reports it costs $8,293 a year to treat one malnourished person. Public expenditures on malnutrition was estimated to be $21,943,572,000 in England between the years 2011 and 2012. The incremental cost of treating a malnourished subject was 2 to 3 times greater than those not malnourished, as reported by Eli in 2015. Barker, Gout, and Crow reported a loss of greater than $86,000 after conducting a retrospective audit of past patient medical records in 2011. Malnutrition shouldn't be the responsibility of the dietitian alone. Rather, it should be addressed by multidisciplinary groups, including health partners, commissions, clinicians, nurses, dietitians, and pharmacy. The following recommendations are suggestions to ensure best practice. All hospital trusts should have a nutrition working group. Every ward should identify members of staff to act as link nurses for food and nutrition. Gain support and commitment from all disciplines to ensure successful implementation of the screening tool. Protected mealtime should be implemented in all areas and signs clearly displayed to inform visitors and staff. Red tray system or alternative should be implemented to identify patients at high risk of malnutrition. Staff need to be aware of their roles and responsibilities regarding nutrition. All patients should be screened. Improve patients' choices of meals and ensure adherence to better food program guidelines. Ensure prompt referrals within 24 hours of admission to a dietetic department. Frequent auditing should be carried out to ensure quality care. Staff should be encouraged to take ownership of the screening tool to ensure accurate documentation. McWilliams, 2008. MUST was developed, and this or an equivalent has been widely recommended in an attempt to improve quality of nutritional care in hospitals and other care settings. National Collaborating Center for the Acute Care. The MUST has been determined to consistently give reliable results. Parker, Gout, and Crow. The initiative brought about a vast improvement in the identification of patients at risk of malnutrition, and care delivery is continually improving. McWilliams. It has proven to be invaluable to identifying patients at risk for malnutrition or undernutrition. Dietetic referrals continue to increase, and nutritional status is treated as a result. McWilliams. A study conducted by Colward, Elia, Sharp, Stratton found patients attending hospital outpatient clinics showed that self-screening involving MUST is acceptable to patients. It's user-friendly and has a good agreement with the healthcare provider screening. MUST is used upon admission and quarterly in Woodbury Muse Assisted Living. According to Mary Centenaro, Personal Communication, on June 12th, Pennsylvania Hospital uses a tool built into their documentation center that triggers a dietitian referral. According to Kelly McWilliams, Personal Communication, June 13, 2017, and Spirit hospitals also have a built-in tool in their electronic documentation to assess for malnutrition. According to John Aker, Personal Communication, June 13, 2017, all 3 divisions of Kennedy Hospital use a MUST and also a similar tool on Surion, their electronic documentation. Ethically, it is every healthcare provider's responsibility to identify anyone who is malnourished or a high risk for malnutrition. As healthcare professionals, it is important to recognize the signs and symptoms and provide early intervention, not only for the welfare of the patient, but to alleviate the financial burden for all stakeholders. As pointed out several times, the cost to care for a malnutrition patient can be extremely expensive. The study conducted by Amirlo, Matusa, Traverisa, Stubtob, and Nazari report that patients that are admitted to the hospital with malnutrition has about 20% increase of cost. The same team also reported an estimated annual cost of $18 billion in the United States due to increased length of stay in malnourished patients. As stated previously, Ilya reports it costs $80 to $100 a year to treat one malnourished person. England reported over $21 billion in expenditures just in 1 year for malnutrition. And Barker, Gout, and Crow found more than $86,000 in money spent at one hospital while auditing charts. Questions to ponder. Has the patient been eating a normal and varied diet in the past few weeks? No. Refer to MUST. Has the patient experienced unintentional weight loss recently? Yes. Refer to MUST. Obesity or fluid balance changes and edema may mask loss of lean tissue. Rapid weight loss is a concern in all patients, whether obese or not. Can the patient eat, swallow, digest, and absorb enough food safely to meet their needs? No. Refer to MUST. Does the patient have loose-fitting clothes, fragile skin, poor wound healing, apathy, wasted muscle, poor appetite, altered taste sensation, altered bowel habit? If yes, then you must refer to MUST. Thank you.